Again, my name is Peggy Chapman. I'm a clinical nurse specialist in child and adolescent psychiatry. I have been practicing psychiatry with children and adolescents since 1976, and I have been treating kids with PANS, PANDAS, and OCD since I got out of undergraduate and grad school in 1976 and 1982, and then but dealing with PANS, PANDAS, particularly PANDAS, since 1998, shortly after Dr. Susan Sweeto, who you'll see in a little video clip later, introduced the concept of PANS, PANDAS. So we're going to go through the slides, and if you have questions, you can hold in the end, and then in the chat box, we might be able to discuss some of them. I know not everybody who's watching this will be live. Let's see, I'm trying to get my slide to come down. Let's see. Okay, sorry. So the first thing is the goals of the presentation are: what is PANS, PANDAS, how is it diagnosed, its historical perspective, review of neurobiology as far as we know it, and other mental health issues and how these all intersect, identifying the medical and psychiatric treatments for a patient with PANS, PANDAS and what to expect, and educational, a little bit about educational supports and what the schools might see and what you might need to do with interacting with them. So first of all, what is PANS, PANDAS? PANS is the overarching concept of pediatric acute onset neuropsychiatric syndrome, which means there is an acute onset of psychiatric and sometimes neurologic symptoms that weren't present before this occurs. So, and then occasionally, or actually predominantly, it occurs with streptococcal exposure and infection. So that is what PANDAS is. That was the original name. And then in 2012, a group got together, large group represented maybe 500 or 700 cases between them, and realized over time that it was more than just strep. It could be mono, it could be Lyme, it could be mycoplasma pneumonia, which I'll show you a little bit later, that caused the onset. So it's an encephalitic-like experience, which is an inflammation of the brain, and then you have neuropsychiatric symptoms as you have a response to that inflammation. And the triggers, as I mentioned, can be group A strep, that's the most common, mycoplasma pneumonia, which is also walking pneumonia, so a lot of people walk around with it and don't know it, they just start acting up. Lyme, viruses including mononucleosis, herpes, flu, etc. We don't have any evidence right now that COVID has caused it, but as all viral infections can, and we would expect some, in the children who've had COVID in China, there is reports of some OCD behaviors and certainly anxiety, but there's a lot of trauma in people who also have COVID. Sorry, I just clicked the wrong screen. Okay. So I want to talk a little bit about the brain because we're going to refer to this area a little bit. So this is the front of your head, and this is the cortex, the covering. This blue area right in here is mentioned here as the audio, but I want to point, actually the audio is here. This is the area we're going to focus on a lot, called the basal ganglia, which is midbrain. If you put a pencil between the bridge of your nose and between your earlobes and met that pencil in the middle, you would be hitting the basal ganglia. Notice under here is the limbic system. This is where all emotion occurs. You have back here hippocampus right here, which is your short-term converting to long-term memory, the seat of a lot of anxiety. Occipital is your visual. Up here is your motor cortex. Here is your frontal lobe, which is where you have thinking and reasoning and wisdom. All this is highly interconnected by a mechanism I'll show you shortly. So this is really an immunologic illness, except it comes out and presents itself as a neuropsychiatric situation. So what happens basically, and I'll give you again more direction later, is when you have an exposure to a virus or a bacteria, your body naturally creates antibodies to fight these infections. When you get a new vaccine for COVID, it is either going to stimulate your antibodies by giving you a little bit of vaccine in a non-lethal form, that's a traditional flu vaccine, or it's going to give you a new form, which is called mRNA, which is a trick by manipulating genetically what is in the COVID vaccine, the COVID virus, and then your body sees it, except it's not live, and it creates antibodies so that when you get it, you aren't going to react because the antibodies are going to be there to take care of it. But in kids of PANS-PANDAS, these antibodies get misdirected and start attacking the brain, especially basal ganglia. And it's an autoimmune reaction that is an acute onset. And acute is an important word to consider in this case. The average age of patients is 4 to 9 years of age. You can see quite a bit occur during this. There are cases older than this. And these were originally done as numbers because Susuito initially noticed PANDAS, and she identified it between the ages of basically 7 and 12, which are the years that strep is really highly prevalent. However, we do know of cases that were diagnosed and certainly probably at late onset of teens and perhaps in the 20s. It's a spectrum disorder, meaning that the variation is huge on presentation. There's a big symptom mix, and symptom severity can be from mild to extremely severe to the point of major psychotic and dysfunction that they have to be in a hospital and in an ICU even. Immune conditions are in 71% of our families with PANS-PANDAS. So that would be rheumatoid arthritis, lupus, ALS, MS, diabetes type 1, and other inflammatory disorders, Sjogren's, hypothyroidism that's caused by Hashimoto's disorder. Many people have this. And can adults have PANS? Possibly, yes. We believe there is, and there's a case that is open public now from Alex Manville, which is a beautiful 26-year-old girl, Princeton grad, very successful in her college, grade school, and high school career. And she was diagnosed after a long decline in college and a lot of psychiatric treatment that didn't really improve her, and diagnosed at around age 25 with PANDAS, was just starting treatment, and she suicided. Now, suicide is not common in this group, but they certainly talk and think about it, but actually doing it is not common. And when they actually took her brain to NIH, they have autopsied it, and they found damage to the basal ganglia tissue that should not have been there. Now, just a comment, obsessive compulsive disorder has been identified for many, many years. You probably would have heard this if you're involved in OCD much, that it seems to be centered in the basal ganglia. So they've already identified that area. They've also identified that area for some eating disorders and for Tourette. And in PANS-PANDAS, it is a sudden onset of either OCD behaviors or a severely restricted food intake, looking like you can't eat, you're fearing choking, you can't eat because you might poison yourself, you can't swallow, so you might spit. Textures become a huge issue. You might really reduce what you're eating because of your dislike of textures or smells. It's one of these two and accompanied by two of the following symptoms of onset and severity. So anxiety, depression, this is not classic, just slowly getting on board anxiety, depression, huge separation anxiety. And it is separation anxiety as classically defined, except it's so intense and so extreme that it leads to a lot of aggression, irritability, oppositional tantrums that can be raging and severe destruction in the house. And so it's a little hard to sort out how much is obsessive worry, which is the anxiety goes like this. If I leave the house, my mom's going to die or something terrible is going to happen. And so I don't even leave her side. I trail her around the house every day. Now, this is in children who don't have this history, who's never had this history, and all of a sudden their life changes. This is what they're focused on. And it occurs suddenly again. Now, in many cases where you're seeing a child who's 13 or 15, they don't have a sudden case presentation, many of them, but they've been struggling with OCD for many years and they have not had a good response. And it doesn't seem to quite sort out. And people say, go check for PANDAS and PANS. So it might be that this initial event happened at age 7 or age 10, but they have a long history of strep, or they have a long history of infections, or there's a lot of strep in the family. That's when we start looking to see if it's more than just traditional OCD. And one of the things we've identified is they're under 12, they can't seem to leave their mother's side. If they're over 12, they make all sorts of excuses why they cannot leave the house. School becomes very difficult, going out, and they might go specific places that they feel very attached and obligated to show up at, or feel it's not as stressful there. But it is common that all of a sudden an active adolescent will just not want to go anywhere and make all sorts of excuses. They have high sensory amplification, light, sound, smells, people chewing, the misophonia issue, which can be already as a phobia, it intensifies terribly. Motor and vocal tics. So all of a sudden they have Tourette-like behavior. Now, all children frequently have small amounts of tics. They come and go, but this is a sudden onset, and it often includes very abnormal movements. They also deteriorate in their handwriting. I'll show you some examples. Their visual motor skills, which is all science and math require good visual motor skills. Choreiform, which if you could see my hands, I would put stretching out in front of me, and they had fine, like finger playing the piano movements. If you had them do that for about a minute or two, not moving their body in any other way. They're hyper. All of a sudden, they get diagnosed with ADHD because nobody knows what's going on. Inability to get dressed, do ADLs. Again, it's a very big range of behavior, but these are some of the things you'll see. Very importantly, before 2012 in the consortium group got together, there was a major disagreement between neurology and psychiatry and pediatrics as to whether or not this existed and whether or not tics actually represented just motor tic disorder or was it PANDAS. And there is still controversy about this, but as a result, in order to get the PANS movement going and saying this really exists and we have a lot of evidence, they agreed with the neurologist to take it out of the initial pick one or two, pick OCD or eating disorder. Eating disorder replaced tics in the presentation, but I have seen a lot of kids where there's no eating disorder, there's no OCD, but all of a sudden they're writhing so bad they cannot be anywhere. They're swallowing so bad, or they're moving their body so constantly that they cannot be in school, they cannot function. And those are likely tic patients. I mean, PANDAS patients. Now, another, continuing on the list. So behavioral regression is another one of the two that you have to come up with. So this is baby talk, thumb sucking. A lot of behaviors that are just like, why are they doing this? They're 8 and now they're baby talking, they're thumb sucking, they want to sit on my lap. Deterioration in school performance. It often looks like ADHD, as I mentioned, but these children have not had ADHD. If they've had ADHD and they've been medicated just fine, all of a sudden it's not working and they'll come to you and say their med's not working. And I'm like, well, geez, that's funny. It worked just fine 3 months ago. What's going on? Because ADHD med does not suddenly change its efficacy. It's accompanied by short-term memory deficits, slow processing speed. So if I was talking at the speed I am right now, they would have a lot of trouble. Executive function, all of a sudden they can't do their homework, they can't complete it, they can't get it turned in. And they start pushing papers around the page and pretending they have got it done, or they lie actually to tell their parents. These children do not understand what's going on in their brain. They're just trying to cope. But as a result, since they don't know themselves as a poor performer, I often have kids with math trophies on their bookshelves, and all of a sudden they cannot make sense out of a simple math equation. So this is how it would present. Sleep disturbances are very common. They have an inability to sleep alone, or they talk and move in their sleep. They might fall out of bed. They're sleepwalking. These are things that they're not normally doing again. They have stomach aches, which is sometimes why they resist eating. They all of a sudden have a bedwetting event or urgency to go to the bathroom day or night. I've had kids tripping over their Xbox wires because they have to get to the bathroom so fast. The teachers and parents hear from the teachers that the child's avoiding classroom because they're always going to the bathroom, and they get in trouble for this. But again, this is relative to their prior behavior. Now, NIH did a study about REM sleep, which is, I think this is in a further slide, which is 11 out of 12 of the kids they tested sequentially. So that's how they did a control, they tested everybody, had disrupted REM sleep. In REM sleep, you're supposed to be paralyzed. This is when you dream. If you dream with non-paralytic behavior, you will act out your dreams. You'll walk through windows, you sleepwalk. But it's supposed to be paralyzed, and these children were active in their REM sleep. And the diagnosis is now, again, one of the other, OCD plus 2 of the things I just listed. And I know you're not going to track it all right now. You can go back and look at it later. The diagnosis is done through history taking, rule outs, and supportive lab work. So I'm going to take a very thorough history of what happened, the timelines. What is the family history and the timelines of their illnesses? And look for other reasons, like children do get rheumatoid arthritis. They do get other illnesses. They do have concussions that cause some of these things. They do have trauma. They do have, teachers who they don't like a lot, and now they're just not going to school because they figured out by week 6 that this is not a person they're going to be able to work with, or they've been yelled at, or they've been humiliated, or they're bullied. All those things have to be ruled out because those are other reasons for sudden school refusal and wanting to stay home. Here is a child before and during the flare. Flare is what we call an onset or during the action of the neuropsychiatric illness. This is a child who you can see was very precise, very good at identifying her. Their penmanship was very good. This is during their event of PANDAS. They can barely write. Their motor coordination is terrible. Their visual field measurements are terrible. And I've seen kids who are even in kindergarten, because it's harder to diagnose in young children. Young children have tics, young children have bits of OCD every so often, they get focused on something. But if you pull out 6 months before how they colored or read their little one sentence stories, you can still see the difference. This is during illness and after. So this is another girl who demonstrates how she drew herself, and this is age appropriate that she did after she was treated. So again, the lines are gone. They just barely can function in terms of this. This is why they avoid art. Even if they love art, they will start not doing it. Science, math. Science and math all require visual motor coordination. This is a clip I'm going to hopefully show you and see if it works. And if it does, yeah, there it goes. This is the visual, and it's somewhat disturbing, clip of a movie you can rent called My Kid Is Not Crazy. Which is how it looks for parents of PANDAS kids. There's a couple of physicians talking. One thing I want to mention, you'll see a girl in her middle school years with a tube out of her nose. They really don't explain what that tube is. She was spitting in her cups. She would not swallow because she was frightened of swallowing her own saliva. For all of a sudden, this happened to her. And for weeks and weeks, she would not swallow. So they had to tube feed her through the nasal tube, you'll see. I'm going to try and get the volume better. I don't quite know what to do. I understand it's not working. Let's see if I can get anything. Ryan, if you can answer the question, is any volume there? I'm not wearing headphones. I don't have them on. Let me see if I can turn it up on the computer. I'm going to try this, see if it's going to work at all. This is the girl who has the nasal tube. Is that any better? Okay, I'm going to stop it. There is no sound. I'm going to just run through. I just wanted to point out something. These are parents now talking. But one thing that you should notice back here on this visual of this child is this boy's face. If you can see that face and that eye, this is often what they look like when they're in distress. They are out of it. They are not communicating. They are far wilder and upset than many people. Now, you know, if you disrupt your child's OCD routine in a way that bothers them a lot, they might get angry at you, they might hit you. But if you have not seen this face, that is not this type. If you saw this child's photo before this event, he would be a totally different face. And this is something parents report all the time. They just look different. They're so eager to show me videos of what their child has become because nobody can believe it. So I encourage you to go online and look at this. My Kid Is Not Crazy movie trailer, and it's available on YouTube or just if you Google it. So I'm going to try and move on. So academic symptoms, I mentioned some of them already: loss of math skills, declining skills in writing. Executive function includes making simple decisions. Very bad short-term memory. This is particularly true in Lyme disorders, tick-borne disorders, slow processing speed. You'll see a change in their work. They avoid high sensory issues. All of a sudden, they won't go to music, art, phys ed because it's way too noisy. They won't do homework, and they become very perfectionistic as an OCD behavior. Not everybody, again, has those symptoms. It's a spectrum, so some of it happens in some and some of it happens in the others, which makes it harder to diagnose. They have poor organizational skills, difficulty prioritizing, all the executive function. So what is happening? So back to this is the basal ganglia again. Now the basal ganglia is made of all these different parts, and you're going to see some research that refers to these. Don't try and memorize them, but it's this area again, but I want to show it to you in a different scheme. But I mentioned that it's the forebrain. It means it has very big connections to all these other parts. All this is the basal ganglia, and it has connections to other parts of the brain. And because of what I'm going to show you next, this is why you get these different symptoms. But also to note that behavior disorders have been noted in this region, as I mentioned. Tic, Tourette, OCD, addictions of the reward center are also here. This is where Parkinson's occurs because dopamine, which is going to be mentioned in a minute, is diminished, and dopamine controls movement as well as focus and attention. So in the brain, here's the basal ganglia now. These are all dopamine receptors start here in the base and go through this area to the different parts of the brain. So if you're in this part and you have dopamine going up here to the frontal cortex, you don't think so well. If you go here, you might have a tic, or you start moving bodies in a weird way because that's motor control. Motor learning back here, your writing. Here is your smell and your sensory back here. Down here is limbic and the area where you can have psychosis. About 10% of these kids do get psychotic. And right here is the hippocampus. I mentioned the seat of short-term memory. The amygdala is right here. That's your fight-flight area. So when all these dopamine tracks go through this area, you get different symptoms as the inflammation is impacting those areas. Now, one way to explain immunology, and I do this with the kids, but it's simple, and I like parents give me a lot of feedback about this, is to understand immunology, you have to understand what is immunology and what does it do. So to make it simple, it's like the Marine Air Force. It's like our armed forces. So the main one is IgM, and it's always patrolling. It's your first defense. It's constantly on alert. It's the first one to show up for any exposure to bacteria and viruses. Number 2 is IgE, and I explain this to kids, this is only in response to allergen exposures. Now, most kids know insect stings, seasonal allergies, peanut allergies as examples of this, and it only reacts to an item that it decides is an enemy of the state of your body. So as you know, you can develop like mold allergy over time with exposure, just like you can have a mosquito bite one time, it swells a little bit, the next time it might swell a lot. Same thing with seasonal allergies. It might be better or worse year to year based on what you're exposed to. IgA is the antibody in your entire mucosa system. So if you think ear, nose, eyes, throat, gut, bowel, bladder, that's all the mucosa. If you look inside your lip, if I was with you, I'd show the inside of my lip, and that's your mucosa lining. IgA sits in that lining. And this is the defense of your first entry of most things you breathe, you eat. This is what also was just discovered only in the last month, or was published, that this is also in the lining of the brain, which has a lot to do possibly with why it gets penetrated if your IgA is not working correctly. About 25% of the population carries a slight deficiency of this part, but no one has identified that deficiency as a major issue. IgG is where we hit pandas in particularly, especially. So IgG is the Navy. It floats to get to where it's going to go in all the blood and fluid. So it also takes a while in the Navy to get to where it's going. So if you're the Air Force, the IgE, you get there really quick. But if you've got to get in a boat and go to war, you get there a little late, which is what happens in PANDAS. So even though the strep infection may have been May 1st, you may not have the antibodies created that are going to impact a child until 4 to 6 weeks later. This is partly what the confusion happens with the diagnosis, because you hardly remember the fact that they had a sore throat 6 weeks ago when you have this crazy behavior show up. However, if you check their lab work, you can spot the antibodies. That's what the lab work is about. But anyway, it floats slowly and it enters the brain through the blood system. And even though the brain is supposed to keep out some of this, it tends to be leaky at certain points. This is what we know to be true for a lot of autoimmune reactions. And it identifies the basal ganglia as a strep because it looks like strep cellularly. It's called cell mimicry. In other words, the actual structure of the cell appears to your antibody IgG as if it's strep. So it starts attacking it. So I tell the kids, your brain is getting the wrong intelligence. The Navy keeps shelling it, except it's not supposed to. The body has been tricked into believing that this is what you're supposed to be doing. And the evidence I show kids is there's a picture. If you look up NIH, Thomas Insel, an article, INSEL, he published a very brief article, but it showed a picture of the basal ganglia before and after treatment, and it is swollen in before treatment. We also know, as I mentioned, the basal ganglia is the site of OCD and Tourette, and they have identified years and years ago with adult brains that their basal ganglia in patients with OCD was larger than average. And I always said, well, why would that be? Well, if you think about swelling, like I point to a mosquito bites, I say to the kid, what does a mosquito bite look like? It's swollen. That's how you know you have it. In addition to the itch, it's enlarged on your skin. So this is the area that this is working unfortunately bad in. In mice studies, rat studies, they track the IgG and they can see it surrounding and invading the basal ganglia. Now, a little more about neurochemistry. Don't try memorizing this, but this is, I'm sorry, I have to go back up. This is the cell that releases neurotransmitters, which are dopamine, serotonin, norepinephrine, the ones we're going to pay attention to. It goes into this space and waits to be sucked up by receptors down here, and then it shoots it back this way. And that's what signals all of our being and all of our activity and all of our brain activity. Even our electronic impulses are created by this chemical movement in our brains. Now, dopamine is, I mentioned, the main neurotransmitter of the basal ganglia, and it impacts all sorts of parts: alertness, cognition. I'm not going to read it all. Voluntary movement. This is why Parkinson's is a big issue here. And in brains of children who have PANDAS, there is a measure in one test that actually measures the receptors of the dopamine. So back to here, these are the receptors. And what they see is antibodies are attacking these receptors. So it's not that you don't have dopamine, it's just that it's not working so well when it's being attacked. And this explains a lot of the behaviors, because if your dopamine is thrown off, you have ADHD behavior. If your dopamine is off, you don't think so straight. Now, dopamine is also connected to norepinephrine. Norepinephrine is another of the three biggies, neurotransmitter it's called. It's our stress hormone. It is, another word for it is noradrenaline. So noradrenaline becomes adrenaline, your fight, flight chemistry. But it creates dopamine. So it is also involved in this, and this is where you see a lot of the anxiety. You see these pupils that are huge on these kids, or they're really tiny pinpricks because their adrenaline is high. I always tell the parents, accept expect an adrenaline surge. These are kids who start cartwheeling at 4 o'clock in the afternoon. They start getting panicky. They start pacing. They start revving up for the night. Even if they had a pretty good day in school, this is what is driving this. This is a norepinephrine imbalance. They also affects concentration, etc. PANDAS kids can be extremely ill. They can have extreme compulsions, licking shoes, barking, motor sounds, whooping, wringing hands. As I mentioned before, that you'll see these also in Tourette kids, by the way, and they do not have PANDAS now necessarily. The episodes are terrifying for both the family and the child. The family is all getting PTSD. The parents in particular who've not ever seen or witnessed their children like this are having PTSD because this is not the child that they've had the day before. And sometimes it's a very overnight event. Many parents can tell you the date and time that this change occurs. It's really quite amazing. They'll say January 15th at 8 o'clock they started barking, or that they started, compulsively not able to move across the room. Or they broke our door down practically to be with us at night. They overlap multiple psychiatric disorders: OCD, Tourette, ADHD, depression, bipolar, schizophrenia if they're psychotic. However, those things did not occur until this acute episode. So if a doctor is clearly watching and paying attention to their DSM diagnostic manual, when they give an ADHD diagnosis to a 12-year-old who didn't have it last year, they are not appropriately giving that diagnosis. You can't just have ADHD all of a sudden. You can't become autistic all of a sudden, which is some of these kids get that diagnosis because they regress so badly. They also have some visual and auditory hallucinations. And these things have also been seen in schizophrenia, of course, bipolar, and also an autoimmune illness, lupus cerebritis. Lupus cerebritis is inflammation of your brain with lupus, which is an autoimmune disorder. Now, the tests that we run typically are similar to this. There are also many more I'm not going to describe, but the beginning is to rule in, rule out strep and other major illnesses that we might be looking for that we know are common. So we try and do a throat swab. I will remind you that throat swabs, you may not know this, are often about 50% of people can't even get a decent one. In order to do a decent throat swab, you have to have somebody swab you in the back of your throat to the point you're going to throw up on their shoes. And I had a kid recently who was handed their own swab and told to swab their throat, and I can assure you that was not an accurate swab. If they have a history of any redness around their anus or irritation in that issue, anal strep is not uncommon, especially in young kids, which is when strep is common. And sometimes also nasal swabs are done because the strep resides not in their throat, but in their nose. We also measure antibodies to strep, both in these two measures, antistreptolysin, which is called ASO, and anti-DNase B, DNase AB. These are blood work. Additional labs blood work, we do look for mycoplasma pneumonia, mono in certain cases, some herpes, tick-borne illnesses, although the standard tick-borne illness measurements, if it's chronic and not acute illness, is often negative, and then you have to look further with specialists. Immunoglobulins are sometimes, these are the more advanced studies. Immunoglobulins, that's measuring your IgE, IgA, etc. These kids typically have reduced IgG in some way. Even though it's hyperactive in the brain, they often have an under amount in their bodies. SED rate, C-reactive protein, anti-nuclear antibodies, etc. And often by the time somebody like myself would see a child, a primary care or emergency room has done the basics: CBC, comp chemistry, that's your liver function, kidney function, thyroid, but often not antibodies to thyroid, which I mentioned earlier, Hashimoto's, which is a disorder of antibodies attacking a woman or a man's thyroid. Then it knocks out the thyroid. These kids often have antibodies to thyroid, but they do not have, weirdly enough, abnormal antibody function. And I mean, a normal thyroid function. Sometimes they do, but most of the time, I've seen kids fluctuate between overactive and underactive within 3 months' time, which is not normal thyroid function. This is the official 3-pronged approach to treating PANDAS. Once you've identified it, you will start with psychoactive medications, theoretically. I'll comment about that in a minute. Therapy and supportive interventions, including school. That's really for mild cases, but I would invert this if I was doing it again. You would first try and remove the source of the inflammation. You would use NSAIDs like Aleve and Advil, and then you might use an antibiotic. When you're in a bad flare, when you're the kids you saw in that video without the language and the words, they cannot do these things. You might use a medication like Zoloft, something small to help their anxiety. You might have to use an antipsychotic if they're friggin' crazy behavior, because as I tell horrified parents, it's either try this antipsychotic to calm them because it's really going to be a tranquilizer at that point, or face hospitalization, because you cannot have a child breaking TVs in your house, trying to jump off the roof, trying to jump out of a car, bashing everybody who gets in their way. So you have to understand that these get really severe. When they're also in that really bad way that child's face portrayed, they cannot do therapy. It's often the parents who are in therapy because they're trying to understand what's going on. But the child it's themselves, where in their brain is this crazy and inflamed, they cannot absorb thinking about themselves in relationship to their behavior. And then in a small group of kids, you have to go further with immunomodulatory and anti-inflammatory therapies, which are called IVIG, or some very fancy autoimmune disordered drugs. I'll talk about that a little bit. So here's the traditional treatments. A lot of parent support. The therapy must be individualized based on the symptoms. So I don't always start kids with therapy. I often do use it because if you have OCD, you need exposure therapy usually, but you can't do it when they're in a panic state. You do it when you've got a bit of their symptoms under control, and then you start to teach them how to counter, just like normal, the talk back to your OCD kind of thinking. And exposure work works really well with these kids, but you cannot do it when they're really, really frightened. They're in a panic state too often of the time about what's going on in their head. Kids have also told us as teens, it's as if I'm in the back of my head watching the front of my head and I have no control over what's going on. They actually do sense that something's really weird, but they often cannot state it or talk about it. Hospitalization can occur with severe symptoms. If you don't eat, you start to lose weight, you endanger your body. Psychosis, aggression, severe tics when they're unable to eat, with a throat tick, a swallow tick, for example. However, the problem is psychiatric units are ill-equipped to treat medical, and med-surg are not equipped to treat psych. Very importantly, since severe anxiety is so common in these kids, separation anxiety, in a medical situation, you would be allowed to stay with your child, however, not in psychiatric units. So it often traumatizes a child further to be hospitalized. I'm not saying don't hospitalize. I argue with parents a lot that they have to be hospitalized because the bottom line is safety, safety of self and safety of others. But it is very traumatizing, as it always is for any family. But if you have a child who is depressed and suicidal and talking about suicide, or suddenly become suicidal, if you've known them to be depressed, it's not as much of a shock as a parent who's had a typical child with no depression, no anxiety, no OCD, no ADHD 3 weeks ago, and now you may be talking about hospitalization. So a good example of this, I have a patient who did have a viral illness in December, and on sometime in the holidays, she announced the family she couldn't be in the car they just bought. By 3 weeks later, she couldn't put clothes on. She couldn't eat. She was in her mom's bedroom with no clothes on, and she was that way for weeks until we got treatment started. I did manage to keep her out of the hospital by using some antipsychotic, but I wasn't sure we would manage without hospitalization because she was so disrupted and disturbed. Removing sources of inflammation, I mentioned antibiotics, and called tincture of time. You may notice in your children OCD experience that it modulates. Sometimes it goes up and sometimes it goes down. Stress always worsens OCD. Illness can worsen OCD if you haven't noticed. And it's a question mark really in my head where the line is drawn between PANDAS and OCD as traditional OCD. But the kids with traditional OCD don't have a lot of these accompanying bad sections. They might do okay in school if their OCD isn't wrapped up in not touching their books to the floor, the locker, because it's too dirty. But if their OCD is home, about the window or the door or touching the light switch, they can often be in school and not be compromised at the level these kids would be. The medications are often penicillin, or Augmentin is a version of amoxicillin and penicillin bases, but also you have allergies many times to those meds, and we move on to other things. There's a 10% chance of all Augmentin type and penicillin type drugs to be resistant, just have strep resistant to those drugs. That's just standard, and all pediatricians deal with this all the time. If you've had your child with strep infection and they don't get better, you know you're going back to a different antibiotic. You dose for weight, it's just the same, except the difference is instead of a 5 or 10 day Z-Pak, Zithromax, you might be on 30 days, you might be on 6 months of it. I usually do a 1 month trial to see, and if by week 3 there's nothing going on, it's probably not going to happen. But I use the NSAIDs, the Aleve and the Advil, because they do quite well to diminish the inflammation, and the behavior will calm down on their way to getting the response to the antibiotics. As I mentioned, the NSAIDs, it's if you even think your child may be having this, a simple thing you can do without getting medical advice from me or anybody else is just to try 3 to 5 days of a proper dose of Advil or Aleve for your child. Now, proper dose is based on weight. It's also based on 3 times a day for, that's TID, for Advil, or twice a day for Aleve. Small children don't do Aleve well because you have to get a prescription usually for the liquid version. But Advil is certainly available, and always, always, always they have to have food before they take this med. So if they're not eating, that's a harder thing to do. And you can read more about that here at the website. And if once they are free of symptoms for some time period, depends on their course of history, then we start weaning them back off the meds and see how they do. Strong probiotics, that's your gut bacteria support, is really important for any antibiotic use because yeast and other bad mixes of your gut bacteria will occur. People always worry about if they're going to develop resistance to taking antibiotics. It's not your child that develops antibiotic resistance. It is the excessive use of antibiotics in our food chain and in our medical chain that have caused these bugs like strep to mutate and not respond to the antibiotic. But it's not your child being on one that's going to mutate. And also, persistent symptoms may require short courses of prednisone, like you would get if your child was covered with poison ivy. You would happily give him prednisone to take him out of his misery, her misery. But you'd have to deal with the side effects. Things that we can use that are psychiatric to help are all the calming medications. That's Benadryl, over-the-counter antihistamines. Hydroxyzine is also known as Atarax. Clonidine and guanfacine are especially helpful if they have tics, because that's a treatment for tics. And also hyperactive explosive disorders are brought down a bit in movement and hyper by guanfacine, clonidine, because they are blood pressure medications, and what they do is they relax your blood vessels by lowering your adrenaline. Benzodiazepines are sometimes used, that's like Ativan or lorazepam, Klonopin, if they're really aggressive. But like many children who have issues with that drug, you have to be very careful. If you've had a negative reaction to Benadryl, you have to be especially careful because it can often translate to a negative reaction to something like Ativan. These doses are low, and because even the traditional drugs for OCD that you can go, as many of you might know, you can go 20 for a depression and you can do 80 for OCD and not have side effects in often many kids with OCD. However, in these kids, they're much more sensitive. They need a lot less, and they don't get great success. This is one of the triggers you start looking for PANDAS is they have no reaction, no major help. You've lowered their anxiety, but their basic OCD is not getting better on these meds, even at higher doses. The antipsychotics, as I mentioned, are used. Stimulants are rarely helpful. In fact, they often make the kid irritable as all heck, because if you think about that dopamine that's not working, you're adding more dopamine to that space. Now you've got more dopamine buildup, and high dopamine causes irritability and anger. Very slow, you start low, quarter to a half dose of these meds. Support and therapy, I mentioned exposure. You can do cognitive work for your anxiety, especially separation issues. Supplements, I won't get into much, but some are used. Not all of them are directly helpful, but there's things like curcumin, which are known to be immune support. I am a big fan of probiotics, and high dose omega-3 is anti-inflammatory, but it doesn't always translate to treating the PANS on its own. It's supplemental. An anti-inflammatory diet is often mentioned, reducing gluten, dairy, sugar, colorants, dyes, all the things have been identified for this. Parent coaching and support. I'm going to move a little faster now because we're getting low on time. The mentioned is the steroids. IVIG is a treatment for very ill children. Tonsillectomy is sometimes done because they harbor the bacteria that might be exaggerating and continuing the antibody behavior. And then in very high risk, extreme life-threatening situations, you can get plasmapheresis, which is where they take your blood out and clean it off and put it back in, or a drug now called rituximab, which is used in children and adolescents with rheumatoid arthritis. They have relapses and exacerbations, especially if they have environmental exposures, including vaccinations, mold, a sibling who comes home, a classmate who has strep, flu going around, et cetera, et cetera. And because of that, the worst cases are in late November to April, which is seasonally ill patterns. And identification of infections at all levels is critical to getting to the underlying immune issue. And sometimes we see strep at first, and then we see mycoplasma, and then I begin to look for tick disorder, because ticks in and of themselves create immune disruption. And there can be a long process between a tick bite you had at 7 and your behavior at 10 that starts to fall apart. And no one puts those two together. So we really comb through medical records. We ask parents about this. They sometimes remember, sometimes they don't. Sometimes they remember later that, in fact, there was a tick bite, because so many of us have them now. There's a long-standing history of neuropsychiatric issues coming from infection. Syphilis was notoriously a bacteria that created psychiatric problems, mania, delusions, incontinence, seizures. Sound familiar? Except for the seizures. Bartonella causes anxiety, psychosis, and rage. That's a tick-borne issue. And viruses are noted to be a cause of brain inflammation. And in fact, this virus is identified higher with people who have these two disorders, schizophrenia and bipolar. Also, the Spanish flu. This is really related now to COVID. This was COVID back in the day of a virus. And it caused hypochondriacy, melancholy, which is depression, mania depression, withdrawing, and catatonia, which people just didn't move at some point. SARS, so you may not know this, but SARS-1 occurred in 2003. MERS, which is a Middle Eastern virus. This was an Asian virus. These are all coronaviruses. This SARS-1 is now we're in SARS-2. This is the official name for COVID, SARS-CoV-2. It has been identified as impairing alertness. In a very severe case, they see a lot of delirium and crazy, just out of people's minds in the ICUs when they're really sick. They see depression, mood, insomnia, anxiety, irritability, PTSD, and OCD has been noted. Now, you could say, but they had OCD maybe, and now they're more stressed. Yes, that's true, but these are people who did not have OCD before they got COVID. These are people who did not have memory impairment, anxiety, insomnia. They all have probably got PTSD if they were very sick with COVID. In rodents also, we've noted that in the olfactory bulb, which is our nose, and SARS goes up that area, and they believe that's why it becomes so difficult so fast in people's brains and why they end up on ventilators, because it invades so quickly into the mucosa, which includes your lungs. So, and the basal ganglia is cited as part of the package as to what is going wrong. I have a question. You can't take antibiotics with probiotics. Wrong. Let me just say that that's not ideal, but my experience is a taken probiotic with an antibiotic is better than a missed probiotic, because you can't figure out the timing. So my experience over now 20 years is to take the probiotic with the antibiotic at breakfast and dinner, and you will get enough effect. If you're treating for Lyme, you've got multiple antibiotics, you have to do more aggressively than that. But if you get a good probiotic, which has two main ingredients, bifidobacterium and lactobacillus, in the billions, not millions, and not on a label that doesn't tell you what's in their jar. Don't buy those. You will be fine. And also, just tell you, probiotics used to be told you take them in between meals, not with any food, blah, blah, blah. Now it's changed because they finally realized that they had no basis for that statement. And they did some studies, and you should take probiotics 30 minutes before or during your meal. And most people who have been using them for many years don't know that change occurred. PET scanning on the basal ganglia, I mentioned this has been a history of this area being a problem. In tonsils, these are now the recent research. In tonsils, these kids had higher cytokine, which means inflation. This cytokine storm is what COVID patients get, which is why they get so ill. They have autoimmune response. The autoimmune response was what kids were noted to have in Europe that they started, and now they have this called Children's Multivariable Organ Symptom Complex, which is what the name is for the illness that children get 6 to 8 weeks later, interestingly, 4 to 8 weeks later after they've had COVID. This is an antibody action of the cytokines going nuts, the antibodies going nuts, and now the children are having organ failure in this case, or very ill. But it's, again, an autoimmune activity that got them ill, not the actual COVID infection. Mice with repeated exposures up their nose release cytokines, and these cytokines break down the blood-brain barrier, which is supposed to protect us from the IgG going into our brain. I'm going to skip some of this. This gets a little more technical. I mentioned the sleep study before. Research and surveys, the parents out of 698 in 2017, 65% were males. That number keeps holding up. And 54% were strep triggered. So the majority is strep induced. 31 patients had a sudden onset in 2017 of OCD, were treated with Zithromax or a sugar pill and probiotics, and they got much better. This is a very good P factor, meaning it's very highly relative, with the Zithromax versus placebo. And patients with OCD, I mentioned, has lower IgA in their brain. This was just discovered. And we knew they had lower IgA in all OCD kids. This study was not specific to PANDAS. This is a Mass General study that came out in 2019, Kyle Williams at the PANDAS Clinic. All OCD kids had a lower IgA than average. And this is a really, really, really important study for you to consider. Of 1 million people in Denmark, because they keep records on every prescription, every illness, everything of their population, after an infection, in particular, schizophrenia, spectrum disorders, OCD, personality behavior disorders, et cetera, are associated with the highest risk after infections. They saw that if you had an infection, i.e., you got a prescription for an antibiotic or a treatment for an infection, that you had a much higher rate than the average citizen of having a psychiatric illness after this was. Now, we've seen small studies like this, but I will tell you, this study blew people out of the water, because look at the number that this measured. This is unrefutable evidence that these things of mental health and infection are connected. The roadblocks, why don't we believe in this? It's a long, muddy history, but let me just say that things take a long time. 1998 was Sue Sweeto's original article. I saw it took 10 to 15 years for pediatricians to even be trained in this. We're now at 2012 when we expanded it to PANS, and we're now only 6 years or 8 years away from that. But most people don't see the articles. Most people aren't exposed to the information. And the American Academy of Pediatrics, still in their 2018 book, said they didn't really think that PANDAS, they weren't so sure it really existed. There's a history of this. When my babies were now in their 30s, we had to put them on their stomachs because that was thought to be the best way to have an infant. Now it has to be your backs, because they discovered on your stomachs you might die in your own breath expiration. H. pylori was thought to be, when I was trained, it was a type A personality. It was their fault, and they had to reduce their stress in their diet and their life. Well, a doctor who upended it all drank bacteria to prove that he could create H. pylori infection, which he did do. He drank it, he scoped himself before and after, and he developed it. And that showed the world finally. But even after that was published, it took many years for the rest of the world to accept this. Psychiatry is woefully lacking, even though there are multiple journal articles in one of their main articles, journals since 2012, describing this diagnosis and how to treat it. So you have medical not knowledge, and you have psychiatry not knowledging. And also the infection I mentioned is triggered, sometimes it's triggered immediately. So the pediatricians do catch it. If they see a kid with strep one day and they're crazy by Friday, they know it's probably PANDAS, and then they look more to the antibiotics. However, because of the delay, they're not always linked, as I mentioned. And they also can relapse and remit from month to month, year to year. I one time got an intake packet on a child who had OCD. Then I never saw him, and I saw him 2 years later for ADHD. And I said to the parents, what happened? The child had severe OCD. And they said, oh, it kind of just went away. Well, I said, okay. So I just kind of sat on that. And 2 years later, he had a massive onset of OCD. And when I checked him, he had strep. And I believe he had a strep infection back then, when he first approached me. These are some of the articles we mentioned. And here's an article to read. If you don't believe me and you want to hear the other side of the story, it's worth knowing what the argument against this is. But these are the two people that are often the counter voice, and only 2 or 3 in neurology. Schools, basically, because I'm running out of time, if you know the student, if it's later in the year, like February, and they've had a wonderful student until February, they identify it really quickly. I've had a lot of nurses and principals go to the parent, go check out PANDAS, because they have seen it. They can't tell you that they have PANDAS, but they kind of hint to you this should be looked at. The children also don't always show it in school. Despite their severe disability at home, they work very hard to cover up their separation anxiety, their OCD, their sensory issues, except they let it all out when they get home. Now, you see this by if you have a child with Tourette, you know that they tick a lot on the way to school, they tick around right when they get out of school, but the teachers don't see it because they're sitting on it, they're suppressing it. You see this with OCD. If the child is struggling but sits on it and pulls back and holds on and doesn't check everything, doesn't want to be embarrassed by their checking behavior, touching behavior, then they do excessive amounts of it initially before they go or when they get home from school. It's kind of this release of that tension. Communication can be a problem. If they already have an identified problem, everybody just looks to those problems and says, well, that's what it is. It's just a new version or a new diagnosis. And if you switch schools or they go from middle school to high school or grade school to middle school, nobody in that school knows them. The history may not be communicated, and therefore nobody recognizes that this is a different child than was previously being taught. The school nurse can often know that link, and there's a help in identifying it. This is a little sheet on by Patricia Doran, who's written a book, and there's some references to her and a woman named Dr. Green at the end about the kind of accommodations these kids need. What's really important is that the accommodations have to be very fluid, which is really hard for schools because different symptoms occur at different times and different intensity of the symptoms. So maybe their memory is not so good this week, but maybe it's not so bad next week. So even tutoring, if they're home, can be fraught with variation because one day they're on, another day they're not. The family experience is fraught with problems. The parents are very afraid. The children have problems with losing friends. These are kids who are quite active socially. Now they don't want to talk to anybody, see anybody. They're frightened to go to dance. Sometimes if they're in dance school, I've noticed they can get themselves to dance because it's the one area they kind of like their second home if they've been dancing a lot, or if boys are in gymnastics or something, or football field, they try anyway. But one kid had to stop. He had worried so much about his mother's whereabouts that as he ran down the field, he had to stop and find her visually on the sidelines, and he couldn't continue to play football. The practitioners, we're very few of us who treat this disorder. You're being blamed by them. Mothers get told it's, your anxiety, go home and behave. And they're misdiagnosing, and psychiatric units dose medicines way too high and knock your kid out. Briefly, this is a really 2 vignettes of the stories of what this looks like. So this is Lisa at 7 years old. She had complete personality change, extreme phobias, rain, tornadoes, cartwheeling was nonstop. That's part of the movement. Hoarding food, wetting the bed, hallucinating. She had a rapid strep. She was given high-dose Ativan. Unfortunately, there was a psychiatric misstep, and this created hallucinations because she was so agitated, they just were trying to knock her out. Her blood was checked because an emergency room physician, on like the third visit by the mother to the psychiatry, to get help for her daughter, said, check her antibodies, and in fact, she was positive. But despite that, and despite some treatment, over 18 months, she saw 5 therapists, 2 psychiatrists, neurologists, and 3 pediatricians. That is not an uncommon scenario. 12-year-old as 12, she got a Gardasil shot. She had a reaction. So 10 days later, she had cellulitis. Her eyes were shut. She had to have surgery because they were so swollen. Then she thought her teeth were falling out, her appendix was burst. She got very somatic. All these tests were done, led to a recommendation for hospitalization, which mother refused because she knew she'd have to be separated from her, and that would be traumatic. They managed to pull through that. I did not get involved with this child till she was about this age, 15, 16. I think I first met her. High anxiety, school refusal. Then the mother had tested at that point for Lyme. In fact, she was positive, and she had also now developed mycoplasma pneumonia and a condition called POTS, which is bad blood pressure movement, and you get really dizzy, you can faint. And she slowly got treated, but I gave her the fluoxetine for the anxiety. The treater for the Lyme gave her the antibiotics, and she did recover very nicely and got discharged. I discharged her after high school, and I also don't treat kids past high school. But the point is she was able to return to school after almost 2 years of fairly high level school refusal and was able to graduate. Even as a 19-year-old, she gets episodes of anxiety, and her mother's always trying to monitor, is this illness based or just anxiety of life? Because people can have anxiety and it's not PANDAS. Another child, 5-year-old, sudden onset preschool, confessing, telling, you know this story. They're going to tell you everything. This is the confessing, telling compulsion. They had hand washing, tics, fearful of choking, so trouble eating, baby talk. There's a regression. Slurred speech, he actually was having neurologic issues, which led to slurred speech, and disconnected socially. Positive rapid stroke, high SAO. And mother is a therapist, by the way, and she didn't know of PANDAS and she didn't know to believe in it, but she just was so desperate she was willing to listen to anybody who tried to describe what was wrong with her child. He had high SO, started on antibiotics, and he immediately got better some. He was diagnosed with it later on at the PANDAS clinic at Mass General. Over 12 months, he had 9 rapid step tests positive, 2 episodes of scarlet fever, which is another strep infection, positive for Lyme and mycoplasma, very ridden with illness. He had separation anxiety, guidance counselor had to hold on to him, difficulty with all these things. Younger brother tested positive for strep 4 times before 1 year old, multiple infections, tonsillectomy, myringotomy, so there's inflammation. Lots of behavioral regression later on as he developed more and more strep. So this is a vulnerability in the family. Now you're seeing some genetics play in everybody else. So it's not uncommon to have more than one child get PANDAS, and it's often developed as they get into those ages where strep is really high, which is 7 to 12. The younger sister, multiple ear infections, low-grade fevers of unexplained, OCD, lability, and rubbing issues, sensory issues, and positive for Lyme as well. So parents need a lot of support. The caregivers, such as myself, really are partnering with parents and holding them together and trying to hold them up, because it takes a team to help this illness, and often they're not having a team, they're just by themselves. Getting assistance for navigating 504s, IEPs, having the strep be unknown in the classroom and the school nurse, using excused absences if necessary, and enlisting the teachers and the nurses to note changes and understand this is an illness that they often can spot before the parent may even be clued in, because they're seeing little bits of it in school around their academic performance, for example. Closing thoughts, kids can get better. Early diagnosis and treatment. If all pediatricians were PANS literate and they could see a sudden change in a child and start an antibiotic right away, we would rarely have anything to do. The sooner you treat this, the better it is. If you let it go and it goes on, the symptoms get more complete, and then you're starting to get into typical OCD treatment, which you know is hard to do. It requires a lot of medication and it takes a lot of time and it requires a lot of therapy. And therefore, it gets more and more, and somehow it changes the brain enough over time that it becomes more and more typical psychiatric, which is a lot of work to get reversed. And you have to really be available to that notion that you're going to be part of a team. Please don't allow the mother to be blamed. I don't know if you have parents of OCD have been blamed, but so many mothers of schizophrenia, autism, PANDAS have been told it's their fault. You know, I'm old enough, unfortunately, you can't see my gray hair, to know about schizophrenogenic mothers and autism refrigerator mothers and eating disorder controlling mothers. By the way, eating disorder has a lot of overlap here in the brain chemistry and the brain biology. And it is medical. That symptoms are behavioral, but not induced from normal chemical changes in their brain of behavior. It's all melded together, however, when you get into brain chemistry, because the same neurotransmitters are acting up from a different source, perhaps, but they're still acting up, causing the behaviors. There are many resources. I want to particularly bring your attention to this one, Rhode Island Pandas Parents Group on the Facebook. You just type in Rhode Island Pandas on Facebook, you should find this. These people are active in your area. They know of who might or might not be treating and diagnosing. I checked not really long ago, and there's not many people still. People in Rhode Island are often going to Washington, D.C., here in Massachusetts, but there are a few down there who are more amenable to looking at it or helping diagnose it, but they will help you find those people and give you advice, and they're really lovely and they're really supportive, and they are a side of New England PANS Pandas, because we try and have chapters in the New England area. And New England PANS is a great organization. I'm the medical advisor to them, and they have put on a number of conferences for this, and they're a great resource. Their website has all sorts of handouts you can go. And similarly, nationwide is PANDAS Network. which NEPANS kind of came out of people who had connected to network and then decided they needed their own one in the area. And then there's a physician network, which has a wonderful publication, which I send to families to give to their doctor, which is called Seeing Your First Child with PANDAS. There are meetup groups. Aspire is a new group trying to meet a nationwide need. And then the journals, these two journals, if you go to PANDAS Network, these two are available on their website. You don't have to pay for them. New England PANDAS, I give you more information here about that. This is one of the examples of one of their their pictures that they lend people. And here's some books. This is the academic ones. These, Saving Sammy and Beth Allison wrote Child Interrupted. This is kind of the complete guide about what you're living with. This is her original book, which is her story about her son, and she went through years of treatment before discovering it was PANDAS, and then got it treated appropriately, and he's now resumed a normal life. But it was some long time before she got the right diagnosis. Many antipsychotics, many meds tried and failed. And so this is a really good primer if you're looking to know. All these can be gotten out of the library. And these are great books for children. This one's just came out, and it's by an 8-year-old from Maine who, with his therapist, helped him write social stories and created a book, and they just published it. The other two are written by adults, but this one's great, written by a kid. They're all good for other reasons. I think this one, as a child, talking to another child, is really helpful. And there's some books about Lyme and PANDAS, other books. There's more and more coming out, especially around Lyme. And Lyme, there's overwhelming amount of books. But Lyme is very debilitating. It's very slow. It's chronic. And it can impair, in the adult people they've looked at, when they've done brain scanning now, they're seeing inflammation brain-wide in people with chronic Lyme, or also called post-Lyme syndrome. And the typical side presentation is really bad working memory and great levels of exhaustion. Those are two calling cards for looking for Lyme. The other reason you look for Lyme is if your child has rashes that come and go, fevers that come and go, aches and bones that come and go, and it's not just growing pains, it's not a fracture in their foot, even though people think it is, etc. And that's it. And I don't, let's see if I can feed into the questions. Sorry about the video, but you can look that one up. And the mother, Sharon, says, my daughter tried to do Bradley's virtual intensive care, too dysregulated. She still has no PANDAS diagnosis. Could be it, yeah. We have to antibiotic question. Where to go next? Bradley and Hasbro do not have, Bradley has recognized PANDAS, but they don't go out of their way to treat it or diagnose it, I guess I would best say. And I don't know the newest on Hasbro. You mentioned partial ARFID. So ARFID is eating disorder. It's a new word that you're going to hear a lot of when a child will not eat, but doesn't meet anorexic or bulimic diagnostics. And it's usually seen in young children. It's very difficult to treat if it's not being also reviewed for PANDAS. It's difficult to treat even if a child has PANDAS, but it's really difficult to treat if you do not know what else is going on. And Dr. Geller, someone said, have you reached out to Dr. Geller? Is someone's asking this mother. Dr. Geller is another psychiatrist besides Dr. Williams at Mass General who does see patients privately. He might be seeing patients. He is a PANS expert, but he is taking very few. Kyle Williams is the main PANS guy, but his clinic is often stuffed for over a year waiting list. However, he is doing research. And if you have a child between 7 and 10, or definitely has PANDAS, definitely had strep, or you can pretty much find out if they had it, you're suspicious about it, even if the rapid test is negative, you can call up there and see if your child would fit into any of their ongoing research, and then they would take you in really readily because you meet their criteria. When I've looked recently to see if they have any research announced on their website, I didn't see any, but sometimes it's not posted, so it's worth looking that way. My email is at the beginning of this, Peggy@PeggyChapman.com. I'm not taking new patients, but I offer any and all support I can think of online. If you contact me by email and explain to me a little bit about your child, you don't have to give me their whole story. I'll ask you the questions I need to know. I'll tell you how to badger your primary care sometimes about getting what you need to get going, and also other resources that might be in your area that you do not know about. So you can reach me again at Peggy@PeggyChapman.com. And that looks like the end of the questions. And if there's no more, I'll wait a couple minutes to see if any, or a minute or two to see if anybody else wants to post anything. I wish I could see your faces to say thank you for being here and thank you for asking the question, being curious. If your child has OCD, could it be PANS PANDAS? Because without asking the question, you will not find the answer. You'll also find when you ask that question to pediatricians, particularly, or psychiatry people, they will either poo-poo it or they'll say, well, no, it's just this. And one therapist recently said to a kid I sent to her, actually, because she didn't have a PANDAS flare. She was normal, except she had anticipatory anxiety disorder, just straight old anticipatory anxiety. And then before she got in the door, she had a massive flare. And she started feeling like intrusive thinking about she was going to self-harm. So she started fearing being in the street, fearing holding the bat in her hand, feeling knives, anything around her couldn't deal with. That was PANS. She was in a flare. She had had a virus a couple weeks before at a place in Maine on vacation. And a couple people in that house had viruses. And the therapist kind of said to her, well, we really don't want to expect that your OCD is going to get any better just because you take an antibiotic. Well, the mother and child had both lived through how an antibiotic actually reversed that OCD, and they had to reverse and get rid of the therapist. So that's how it can go. You think you're in the right place, and it doesn't always happen. So if you need some help thinking through, Carla and Ryan are also well versed in this and can sort out what is possible, but it is not easy, unfortunately. We're working to try and provide more services, but it's tough. It's hard to do this work. It's hard to get support to do this work. And so it limits how many people are willing to do it. Another comment, our ENT here in Memphis is on a PANDAS network page, but difficulty time ordering IVIG. Yeah, he should reach out to the PANDAS network because those people are Dr. Sweeto, Dr. Frankovich, all the experts around the nation to see if there's somebody else who can talk with them and help them suggest how to go about getting it. They're available to be consulted to, so that's ppn.org, PANDAS Physician Network, and that's a really good resource for